much, Dr. Mahapatra and Dr. Sadanan Shetty, for giving me this opportunity to talk on a very important subject, SGLT2 inhibitors in heart failure. Where are we today on the occasion of World Heart Failure Summit? What's the good news? The good news is SGLT2 inhibitor in heart failure has come to stay. Safe, effective, and promising. Better compliance. It is the agent of first choice in heart failure, along with ARNI and diuretics in beta blockers, and can be used both in diastolic heart failure, systolic heart failure, with diabetes and without diabetes. It may help in prevention of the heart failure, in the worsening reduction of the heart failure, as well as in the treatment of the heart failure with enormous mortality benefit. Now, the limitations are also there. The limitations are, especially in females, since there is a glucosuria, they may have a UTI, female more than males, especially the candidiasis, and very rarely one can get URI, joint pains and back pains, and very rarely you may get ketoacidosis and dyslipidemia reported in some of the patients. This is to show the whole history. It took almost 90 years to evolve SGLT2 inhibitors. It took 20 years to find the receptors to be identified and bring it to the action as we are seeing it today. Empagliflozin in 2016, and Kenna in 17, and DAPA in 19, and subsequently 20. What is my agenda of presentation today is to discuss about the safety, efficacy, outcome evaluation of this agent in diabetes with heart failure, and of course, morbidity and mortality benefit. The scenario of heart failure you're already seeing since morning is huge, 10 to 20%, and is very high in diabetics with the advanced aging. For each 1% rise of HbA1c, the risk of heart failure is by 10%. So diabetes is a real risk factor, and we see that the mortality is high. You just saw Sadanan Shetty talking on CHARM data, as well as the paradigm data, which has shown the CV mortality is quite high and the over mortality is also quite high. Why heart failure in diabetics? I think is very important because the shared risk factors and comorbidities has already been expressed. The mechanism is very well known of heart failure in diabetes. There are hyperglycemia, cytokine activation, and RAS activation, giving rise to a left ventricular hypertrophy, diastolic and systolic heart failure. And we see here the survival probability is definitely reduced in the patient of diabetes with heart failure, and we see double the risk of complications. And this is just to show that the impact of diabetes, this is the important slide, and which shows heart failure in diabetes is an amino octet. The various octet components are seen here, from ailing heart to a failing heart, and increasing the hospitalization as well as the CV deaths. This has been proved beyond doubt that the anti-diabetics like insulin, sulfonylureas, metformin, or incretins, they reduce the sugar, but they don't reduce the development of heart failure or reduction of the heart failure. SGLT2 inhibitor are therefore a novel treatment strategy for diabetes with heart failure and heart failure without diabetes, and are insulin independent action. We see here, it is the most important thing is the proximal renal tubule, where there is a 90% of absorption of glucose that is being taken care of and is blocked by SGLT2 inhibitors. This is just to show the renal tubular threshold variability with the normal sugar, with the hyperglycemia, and hyperglycemia with diabetes, and how SGLT2 inhibitors are definitely modulating the issue. And we see here the protection potential of cardiac, renal, vascular, and upward body is by SGLT2 inhibitors by enhancing natriuresis, osmotic diuresis, reduction of E by prime ratio, systolic and diastolic function improvement, reduction of preload and afterload, reduction of fibrosis and LV mass index, remodeling, and NES3 reduction. We already seen in the previous speaker slides, renal protection, vascular, and body protection, and a huge anti-inflammatory potential of this drug has already been documented, thereby reducing the heart failure hospitalization and mortality reduction. Now, do SGLT inhibitors cover all? The answer is secondary prevention is definitely taken care of for hospitalization of the heart failure and renal disease, as well as for MACE events. So far as primary prevention is concerned, MACE is not taken care of. Evidences of outcome benefit by clinical trials is very well documented by EMPA-REG outcome trial in 2016, which is a large trial, shown 35% risk reduction of the hospitalization in heart failure. And we see here the CV death and heart failure hospitalization reduction by 34%. And if you see the reduction irrespective of the dose, both in 15 and 16 has been very well documented. So empagliflozin has shown its influence both on the primary composite points and secondary composite endpoints, and it favors empagliflozin by reduction of mortality of CV as well as the overall mortality by about 32%, and the hospitalization is by 35%. The second study is canagliflozin. Cana was already published in 2017. It has shown that 33% of reduction of the heart failure is very well seen and favors canagliflozin. We see here the 32% reduction in the CV deaths and heart failure hospitalization. Even the reduction of A1C and systolic blood pressure is significantly reduced with the cana. And we can see here the primary cardiovascular outcome is significantly reduced and favors canagliflozin. Primary CVD outcome favors canagliflozin if you summarize the whole data of CANVAS trial. And if you see here, the NT-proBNP and HS troponin are significantly reduced, which was recently published. Similarly, canagliflozin also reduces E by prime ratio, LV mass index, and improves hemoglobin and hematocrit. And you see here, the E by prime ratio is reduced, and ANP and BNP both are reduced significantly when we use canagliflozin. The third trial, which has been highlighted by our previous speakers, dapagliflozin. DECLARE TIMI 58 has shown very clearly that there is a reduction in the primary endpoints and secondary endpoints in the DECLARE, and hospitalization of heart failure is reduced by 27%. Primary endpoints have also shown 17% reduction of the CVD and HHF in the primary endpoints. CV deaths and heart failure hospitalization is seen better with dapagliflozin as compared to placebo. And it's also seen the MACE is also reduced by dapagliflozin as compared to this. The fourth trial is also very, very important, which was very well highlighted by Dr. Manoria, DAPA heart failure trial in 2019. And the main aim was to evaluate dapagliflozin in patients with the reduced heart failure. And it has shown worsening of heart failure is reduced by 30% and CV death by 18%. And the heart failure hospitalization and CV deaths are reduced by almost secondary outcome 25%. And if you see the first and the repeated hospitalization of heart failure are also reduced by almost 25%. This is the EMPEROR trial, which is EMPEROR reduced, which has shown recently in 2020 primary endpoints. Relative risk reduction is by 25% and absolute risk reduction is by 5.3%. And we can see here the total heart failure hospitalization. First hospital hospitalization and the recurrent heart failure hospitalization is reduced by almost 30%. Overall, CV outcome trials have shown that canagliflozin, whether by CANVAS trial or CANVAS-R or Credence, work at the level of both primary and secondary prevention of heart failure. Dapagliflozin also have the similar role at the level of primary and secondary prevention, while empagliflozin and L2-gliflozin only in the secondary prevention. To compare, these three trials have shown that both empagliflozin, dapagliflozin, and canagliflozin had almost 32 to 35% reduction of hospitalization in all the groups. What do the guidelines say? The guideline answer is very simple. Empagliflozin prevent or delay the onset of heart failure and prolong the life. And if you see the latest data, evidence of CVOT and ADA and EASD recommended SGL2 is a preferred treatment for diabetes with heart failure. And in AHA and ACC guidelines in 2019 have shown very clearly that the primary prevention of cardiovascular death is best seen by SGLT2 inhibitors. Similarly, Canadian Cardiac Society and CHF Heart Failure Society guidelines have shown canagliflozin in heart failure hospitalization, diabetes, as well as renal dysfunction is a strong recommendation with a high quality evidence. FDA has approved, this was already highlighted by Dr. Manoria, FDA approves dapagliflozin to treat heart failure with reduced ejection fraction in adults with or without diabetes may be a game changer in the years to come. This was a huge data we published in our book last year. This is one of the bestseller and best reviewer book out of all the books which were published by me in last 11 years. Now, how do we compare these trials? Head-to-head comparison of these trials is not possible, ladies and gentlemen. The promise of ganagliflozin is as follows. The composite outcome of hospitalization by heart failure or CV death credence is more as compared to Emperor R or DEPA-CKD. The reduction of CV death credence is more as compared to Emperor R. And then if you see the reduction of the hospitalization with a heart failure, credence is more as compared to Emperor R. And the all-cause mortality is again credence is more as compared to Emperor R. But the promise of empagliflozin and dapagliflozin, comparing EMPA or DEPA, the composite renal outcome, Emperor R is more and DEPA-CKD is more than credence. And all-cause mortality of DEPA-CKD are more than CANVAS or credence. The upcoming trials are delivered 2021, Empire HF 2021, and Preserve Heart Failure 2021, and Solo Suite in the worsening of the heart failure will be in 2022. To conclude, ladies and gentlemen, heart failure is a major health problem. One should consider very meticulously how to approach our patient. It's not only diuretics, it's not only beta blockers, it's not ACE inhibitors, it's not only ARNI or MRA, but SGLT2 inhibitors is a very important modality of management in patients of heart failure with or without diabetes today. Prevention and treatment of heart failure hospitalization reduction, mortality reduction, as well as MACE reduction. There is an enormous mortality benefit. If you see the CVD mortality benefit, as well as the overall all-cause mortality benefit is up to a tune of 51%. What's the take-home message? The message is health of millions is at stake with heart failure in diabetics and hypertension and metabolic syndrome in India. Timely intervention with SGLT2 inhibitors is the need of the hour. Enormous mortality and morbidity benefit has been shown in the last 4 to 5 years. We must act vocally, locally, focally, and impact globally. I think it's very important. We must individualize our patients, which agent to be given when. SGLT2 inhibitors, MRA, ARNI, ACE inhibitors, ARB, diuretics, or beta blockers. Thank you very much for your kind attention. I'm very grateful to you for giving me this opportunity to interact with you. Thank you.